to extend a special and warm welcome to our Hallman lecturer, Professor Alfgeir Kristjansson. And Kelly will introduce Dr. Kristjansson more explicitly in a few minutes. It's so fitting to have Dr. Kristjansson with us, as here in the Faculty of Applied Health Sciences, or AHS, we're concerned with understanding and finding solutions to complex problems related to health and well-being of individuals and communities and populations, and those that are faced every day. This year, as we continue to celebrate our 50th anniversary, we're really cognizant that we're not only celebrating that 50 years of achievement, but looking forward to the next 50 years of teaching and research and service contributions in the fields of health and well-being, emphasizing three main principles: partnerships, leveraging technology and innovation to maximize the impact of our work, and building our international reputation. So in that context, we're especially pleased to welcome Dr. Kristjansson to speak about this very important topic today. Our faculty recently released the News to You magazine, which gives you some insight into our work that changes the lives of Canadians, and it's under the theme of leading a new conversation. And that extends our last year's theme, which was relationships and health. The feature story in this year's News to You looks back to the roots of the Faculty of Applied Health Sciences and traces the story of the faculty's impact over the past 50 years, demonstrating our pioneering research by early faculty members and the seeds that laid the foundation for much of the research that is happening today. If you'd like to receive a copy or more information about this, I see that Wanda Deschamps, the Director of Advancement from Applied Health Sciences, is right there. If you put your hand up, there she is. She'd be happy to assist you, pass on this information or a copy of the News to You. One of the seeds of the foundation of our work here was recognizing the significance of global health. Now one of the pillars of the School of Public Health and Health Systems. So we look forward to Dr. Kristjansson's perspective on pressing global health problems, especially related to the subject of adolescent substance use and abuse. The topic of substance use is top of mind in Canada for a number of reasons, and very timely right now. Some of those reasons include the federal government's upcoming legalization of recreational cannabis, not cannibal use. That's a whole other issue. I don't know if you're prepared to speak to that today or not. Cannabis use, effective maybe July 1st, 2018. And at a local level, the time is also now for innovative thinking in the realm of health and well-being, because we're, like many other parts of the country, also facing issues with the rise in opioid abuse in the region and many other challenges in this same theme. So it's imperative, obviously, that the university and AHS in particular are involved in addressing these areas that are characterized as wicked problems of public health, given that we do have particular knowledge and expertise in these areas, including along the lines of effective programs and how that could look when applied to the region. However, of course, these aren't matters just for universities to address alone. It's necessary and critical to engage the broader community, and so it's really nice to have this format where the community and members of the university can interact to discuss this crucial topic. In keeping with being engaged, one of the tangible ways that AHS demonstrates our commitment to promoting health and well-being is through this lecture series, which is called the Hallman Lecture Series. We started the lecture series, as Alfgeir and I were talking about before the talk today, by bringing in the Honorable Anne McClellan, who was Deputy Prime Minister of Canada and a former health minister, and she delivered the inaugural Hallman Lecture for the 50th anniversary year on the legalization and regulation of cannabis. Today we're happy to continue the conversation by presenting this Hallman Lecture, which was made possible through a legacy that was created by a generous and visionary philanthropist who I'm just like to tell you a little bit about at this time. So Lyle Hallman was a developer and contractor and philanthropist in the KW area, and he was the recipient of many awards, including the Order of Canada and an honorary doctorate from the University of Waterloo, making him an alum of the Faculty of Applied Health Sciences. Generous donations that were made by Lyle and his wife Wendy to the Faculty of Applied Health Sciences created a number of endowments to expand and sustain health promotion activities within the faculty. These endowments have had a significant impact on health and well-being of our community through research activities and the spread of knowledge related to health promotion through many outlets, including sessions like we're going to experience today. So I'd just like to take the opportunity to thank the Hallman family for their generosity. Through their giving, we've been afforded the opportunity to look at some of the crucial issues related to health and well-being and explore controversies and challenges and opportunities inherent to public health and research policy. So many other alumni, in addition to Mr. Hallman, contribute to the success of the Faculty of Applied Health Sciences and the health and well-being of our broader society. And AHS likes to recognize significant achievements of such valuable contributions through 2 awards, our Alumni Achievement Awards. So we have an Alumni Achievement Award and a Young Alumni Award. It so happens that the nomination window for those awards opens today and goes through April 30th. And again, if you have ideas of good candidates, only criteria is they have to be AHS alumni, please bring those forward, again, through Wanda or through communicating with any member of the Faculty of Applied Health Sciences. On this note, I'd just like to thank our partners at the Waterloo Crime Prevention Council for their collaborative efforts in upstream prevention and acknowledge their ongoing leadership on drug-related issues. So thank you very much, and thank you for joining us today. And I'd also like to thank the lead organizer of the event today from UW, Kelly Anthony from the School of Public Health and Health Systems, and invite Kelly to come forward to introduce our speaker more explicitly.
Thanks, Jim. Thank you so much again, Jim, not only for those words, but for helping to make this happen through allowing us to access Hallman funds. Thank you to the Hallman family. Thank you so much. And of course, our co-sponsoring departments are Recreation and Leisure, and Troy Glover is the chair of that department, and Craig Janes, who I'm not sure if he is here yet. There he is. Hi, Craig. School of Public Health and Health Systems. So this is also a co-sponsorship between those 2 departments as part of our faculty and with the Crime Prevention Council. I'm going to say a few words and then get us going with Alfgeir. Some of you know me. I am not a researcher. Oftentimes people who bring Hallman speakers here are important, serious researchers. I'm a teaching professor, as some of you know. This is the intersection. This is the most exciting intersection of my avocation and my vocation of my career. This is the manifestation of what I do in class with my students to connect them with the community and try to encourage them to be change makers on the ground, and the research that Waterloo is famous for by many of my colleagues who are kindly here today. I, a couple of years ago, saw this terrific assertive little organization called the Crime Prevention Council and asked if I could sit on their board. I cannot believe I begged to give the time that I give them. And I suppose I again have to thank Craig Janes and Jim Rush for letting me give that time. And since then I have become increasingly more involved with the Crime Prevention Council. This was the ideal discussion to have with our community. And by our community I mean Waterloo, University of Waterloo, but also the Waterloo region. We are so enthusiastic to have Alfgeir here. When we first started reading about the work done in Iceland, some of us said, is there a possibility this could happen in our region? So we started making comparisons. Well, we're not exactly, we're socialist leaning, yeah, and we're a fairly well off region, and we started making size comparisons because the Waterloo region looks a little bit like Iceland in terms of size. So we thought maybe we could pull this off. No, we have dreams that this could be the beginnings of conversations about what is possible in our community to protect our kids even more than we do. So I won't say any more than that, other than that we are so delighted to have Alfgeir Kristjansson here, and I'm going to give you a little bit of a bio. I'm not as polished as my dean, but I do have this part written down thanks to Alfgeir. Dr. Kristjansson is from Iceland. The adorable bio in his West Virginia University says that Iceland is in Europe, is one of the Nordic countries, which I thought was so cute. I crossed that out. I'm assuming you know that. He's been at West Virginia University since 2012. He, prior to going to WVU, studied in Iceland and in UK at the University of Edinburgh and at the Karolinska Institute in Sweden, where he earned his doctorate in social medicine. He completed postdoc training in Columbia, I imagine you know where that is. And Dr. Kristjansson is the Senior Data Coordinator and Analyst of the Life Course Study, which is a large registry database cohort study in Iceland funded by the EU, which is a birth cohort of children followed from the age of 12 onwards, and then some retrospective data to allow them to look at multiple data banks pre-birth through age 12. He's also the co-PI on a primary prevention initiative in West Virginia. And I won't tell you too much about West Virginia, but you probably have some idea that the move from Iceland to West Virginia was a big one. That's entitled the Integrated Community Engagement Collaborative, ICE acronym, to promote adolescent health and positive development in West Virginia. No mean feat. Dr. Kristjansson also serves as the PI and CI on a number of federally funded evaluation projects in West Virginia. Finally, Dr. Kristjansson is the Senior Data Coordinator for the Youth in Europe study, a large cross-sectional health and behavior survey of 15 to 16-year-old youth across 15 cities in Europe, and he's actively involved in child and youth research with scholars from his home country and the UK, Sweden, and the US. Without further ado, Alfgeir Kristjansson.
I got this thing.
Nice.
Hello? You can hear me, yeah? Good afternoon. Thank you all for coming. Thank you for having me. Thanks to Kelly and Jim and everybody. It's been a terrific experience so far. I want to tell you right away that I'm not a native English speaker, so I may stumble on a few words or have to sort of think before I remember. I still sometimes have to translate before it comes down to my mouth, especially in a setting like this. And for a foreigner, this is a little bit of a kind of an intimidating kind of setup. There's this big wall of people, and I'm just standing here. But usually, I can make myself understandable. So what I'd like to do is to tell you as much as I can about what we've done in Iceland to change a culture, really. We were drowning in alcohol, really, and along with that, we were way too liberal on drugs. We were indifferent, really, about what our kids were doing. And although we all believed that Iceland was, and it certainly is, comparatively a very safe country with low crime rates and a homogeneous population, we were basically caught with our pants down in the mid-90s. And I want to tell you sort of the story of how we were able to change those trends by focusing on a holistic cultural shift. So before we go there, I want to show you a couple things. So this is the local hike. This is Reykjavik city, and this is Mountain Esja, which is sort of a nice kind of local hike. So if you ever go to Reykjavik, there are direct flights from Toronto. They're pretty affordable too. I don't get any percentages or anything, but it's a nice thing to do. It's about 800 meters. It's pretty steep, so it's kind of a good kind of hour and a half walk, and I would recommend it. I try to do it every time I go home, which is actually pretty frequently. This is me and my little guy, Ymir. I have 3 boys. He is the smallest or youngest of the 3. He's born in the U.S. and is going to run for president one day. So we will have President Alfgeirsson, because in Iceland we go by first name, and then our children go by the father's first name followed with a son if it's a boy and a daughter if it's a girl. So my boys are Alfgeirsson, which means that they're my boys. And he's going to be President Alfgeirsson. So now you know a little bit about me, a little bit about Iceland. Iceland is one of the Nordic countries, which is Norway, Sweden, Finland, Denmark, Iceland. And then we count typically Åland Islands, which is part of Sweden, and the Faroe Islands, which is a part of Denmark. And Greenland is sometimes counted to be part of the Nordic countries, even though it really isn't. It's about not as cold as Greenland. People in the U.S. always tell me, isn't Iceland green and Greenland ice? Isn't that how it is? And somehow, for some reason, people have learned that. And yes, that's more or less true. Greenland is an ice shell, and Iceland has glacier, but is mostly not ice shell. Population about 300,000, which is obviously not a lot. Reykjavik capital area is here, and on this corner we have about 65 to 70% of the population. So all these areas around the shore are small towns and villages. Language Icelandic, we have one of the smallest serving currencies in the world, which means that we are really fragile for inflation and high interest rates and so on. And we can talk about that at another time. And then most people in Iceland believe in elves. So I'm not saying that they worship elves, but they do believe elves exist. And there are good reasons for that. So if you ever go there, you'll sort of see that in the landscape. Probably the original reason why I'm here is because of this article that appeared in the British newspaper, The Independent, in January of 2017. It was written by a reporter called Emma Young, and it was subsequently distributed in Mosaic Science, the Huffington Post, the Atlantic, and several places. And it's been drowning us basically with requests since this came out. And I really don't know why this happened now, because we've been doing this work for 20 years. But subsequently, the BBC made a short video of what was happening in Iceland that you can find on YouTube if you're interested. It's about 7 minutes. It's pretty well done. And they chased some people around and tried to figure out, put it into like a footage format. And this is sort of a news story briefing of what was done over there. So let me take you back to try to understand the context. How were things really when they were really, really bad? So this picture is taken in downtown Reykjavik in the mid-90s around 4 a.m. on a Friday or a Saturday night. I know it's pretty bright, but in the midsummer in Iceland, it really doesn't get dark at all. In December, it's dark all the time. So we have these sort of extreme shifts. And this basically shows the atmosphere in Midtown Reykjavik at 4 a.m. On a weekend. Pretty typical, packed with people, everybody drinking, a lot of young people and a lot of underage drinking. And people knew about this. They were fully aware of the situation. It was sort of accepted. That's just how things are. But when our comparative statistics started showing where we were compared to other countries, people really got alarmed. And in the beginning, we came to realize that even on a European scale, our shape was pretty bad. This is from the European SBAT study. You guys know the Monitoring the Future study, which is the longest serving adolescent drug use survey in, I think, the world. It has been going on since 1975. The SBAT study is basically a pan-European survey of a very similar kind. It tracks adolescent drug, alcohol, and tobacco use today in about 40 countries. This started off in 95 with 20 countries. This survey showed us in a pretty bad light. We're number 5 there of 20 countries, and these are rates of or proportion of girls and boys that have been drunk 10 times or more often in the last 12 months. At the same time, our comparative statistics on drunkenness for the first time at the age of 13 or younger were also very high. So basically, I got a 12-year-old boy. The fact that he's 1 year from becoming drunk compared to what these numbers show is just absolutely mind-blowing. And so that was another typical indicator. Overall, in the SBAT studies, we were near the top or at the top in many different categories. So let me, to begin with, tell you 3 things that I want you to know before I get any further. Oftentimes when we talk about what was happening and has been done in Iceland, people tend to wait for the one golden standard. What was the one really, sort of major shifting thing you did? If you are waiting for that answer, I'm not going to be able to give it to you, because it wasn't just one golden thing. It's changing a culture takes time and requires a lot of moving parts. So the Icelandic model is not a program. It's a community building system for the long haul. The individual elements of what we do and what we have done are not new. Most of this is in some way available in countries with advanced infrastructure, and as far as I know, they're all available here as well. We probably just put them together slightly differently. And if there is one thing which is critical, then it is collaboration. And at the same time that collaboration is key, it is also the realization that in the absence of collaboration, not much is going to happen. In other words, if we do community building, I as a researcher am always going to be an external to people in communities. In other words, I can't walk into a community and just tell people what to do. That's not how it works. Nobody wants to be told what to do in the first place, and I don't have access to people in that way. So collaboration is key. In a nutshell, what we are trying to do and have been able to do in many ways is to integrate the process of research, policy, and practice. We have lots of students here. We are led to believe that research informs policy that then will lead into practice. That's sort of how we like to believe this thing works. Scholars like me do research, we write our research papers, and we have this one paragraph in the discussion section where we say that this groundbreaking study and these fantastic findings will inform new intervention programs, blah, 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 blah. This happens almost never. Almost never. And this process is not linear and clear, as this suggests. It almost never is. If you have ever worked with people at the municipal, area, district, province, or policy level generally, they do not have the means or the time to really consult with the peer-reviewed literature. It's just not how things tend to work. Obviously, we would like for that to be the case, but it requires much more than just to conduct a review of the literature. There's a whole translation piece that is really, really complicated. And we, as researchers, we tend to study smaller, and tinier, and more significant niches in order to advance and pull and move the needle a little bit more in knowledge making. So, just to underline, this process is not linear. So, unfortunately, what tends to happen often is that the researcher is sort of looking ahead. She, in this instance, publishes papers under the university and research scholarship system that we operate, and most of them just fly by the policymaker. And that's just a fact, you know. This is just how it works very often. As a result, the policymaker is trying to communicate with the practitioners. They're blindfolded because they really don't have good directions. We'd like to believe that everybody is doing their best. That's, you know, I'm not going to talk down on people working in policy or practice. I believe that those people are absolutely, and we are all trying to do our best. What I'm trying to underline is that these three sections are siloed, and they're very kind of separated, especially when it comes to immediate collaboration. What we would like to do is to get those major pillars to talk with one another. Get people in research not only to talk with people in policy. I would like to see the researcher talk directly with practitioners, and I would like to see the practitioners come back to the researcher to talk about what we have observed as practice-oriented knowledge. And there is such a thing. There's practice-oriented knowledge as separate from academic knowledge. If all those entities can really work closely together, we have a much better chance of creating change in the lives of real people. And essentially, that's been what we believe Iceland has been pretty successful at. So let me move to the model. I don't have any time. I'm good. All right. All right. I've got a lot of slides, so I'm gonna maybe start talking faster. Okay. So essentially, first this. In 2010, Tom Frieden, who's Tom Frieden? head of the Centers for Disease Control. Well, former head of the Centers for Disease Control. He wrote this paper and published in the American Journal of Public Health titled A Framework for Public Health Action, the Health Impact Pyramid. And basically what this paper concerns is to try to demonstrate through this diagram how increasing individual effort is needed to provide more individual level services or intervention services with subsequent decrease in population impact. Do you follow me? So really, the approach that we are most commonly used to in prevention is to turn our focus on this area, to basically work on a one-to-one setting. This is where our hospital system is, for example. We wait for people to get really sick. We treat them individually. It costs an enormous amount of resources, money, manpower, time, and so on. But we spend much less emphasis on the lower parts of the triangle, which really concern prevention at the primary end of things. So he says, personal lifestyle is socially conditioned. By the way, if you're from sociology, we knew this in the 70s. Individuals are unlikely to eat very differently from the rest of their families and social circles. It makes little sense to expect individuals to behave differently than their peers. It's more appropriate to seek a general change in behavioral norms and in the circumstances which facilitate their adoption. And the Iceland system has been about this. It's been about changing the context so that individual default choices and decisions are healthy. That's really what it's been about. In a figurative manner, this is really what we do in many ways, how it works. We view individuals inside school communities as social products. So children are environmental products. That's our central theoretical viewpoint. They are products of 4 major domains that are located within local school community. And we say local school community not to point the finger at the schools, which is so commonly done, but to underline that schools are organized by geographical districts, right? So children that go to a given school, they are also likely to live around that school. They're also likely to have parents that live in the area around that school. So basically the school is like a central unit where people in the area have children that go to the same school. So if it was a different institution, we could just, substitute it for the other. So the school is just there because it's helpful as a moving unit. We then work with well-defined risk and protective factors in these 4 major domains: parents and family, leisure time, peer group, and school the school environment. Children spend about 90% of their time in their school community. But obviously, and in Iceland, the municipalities, which is the next circle around, they both fund the schools and they fund most of the recreational and extracurricular activities that are available to children. So if we are going to get any kind of buy-in at the community level, we have to work with municipalities too. And in fact, to just speed things up a little bit, the municipalities are our primary funders. They fund this program moving forward, and they are in charge of the school communities. The national government, which, the country's government, is then around the entire thing. They fund a tiny little portion of it, but we make sure to nurture that relationship carefully and make sure that they are on par with everything that's going on, and particularly the Ministry of Education. So back to the notion of children being social attributes or social products. In short, a child that is in very good standing in those 4 major domains is well supported by their family, well monitored, has good friends, interesting things to do, participate in organized leisure time activities, has good access to that, and is happy in school. Doesn't have to be an A student, just happy in school. Children with that profile are very unlikely to initiate drug use. We all know that. Everybody knows that almost. Okay? If we all know that, what is it that we have to do? What we have tried to do is to drive down risk factors and strengthen protective factors within those 4 major domains. This primarily originated in literature from the US, so it's not specific to Iceland. In fact, if we look at risk and protective factors at the basic level in these 4 major domains, they're very similar across different places. We know these things pretty well and have known them for a long time. There really isn't much new under the sun with regards to risk factors at the absolute basic level. So this is in a nutshell how it works. Just briefly on the background. The initial measurement in Iceland began with something called the Educational Research Institute. They conducted surveys that showed our terrible status and as well as the SBAT studies. The project called Drug-Free Iceland 2002, which embarked on a lot of controversy around the title of it. Are you going to make the country free of drugs in 5 years? And then again, people came back and said, well, are we going to say almost Drug-Free Iceland 2002? Is that better? Obviously, that's not better. We're going to aim for, the aim high. They initiated this kind of system. And the original thinkers behind this were people from sociology and criminology. They were not people from community health or people that really had much applied background, but they were micro-sociologists mostly. And for them, they used classical sociological theory, Durkheimian theory, classic theories of criminology, Hershey's control theory, those kinds, to really understand that there is a set of commitments that we can work with in the lives of adolescents that really should deter them from delinquency, including drug use initiation. So prevention work was based on sociology, criminology theories, and at this time, collaborative efforts among researchers, policymakers, and practitioners in administrative leadership begins. The Center for Social Research and Analysis, where I have had an appointment since 2004, took this over in '98 and has been working with it until the present. Our surveys are similar to the Monitoring the Future study, but we include a number of measures also that are more specific to our environment, and we leave a space for development and change on an annual basis as well. The focus of our work is on primary prevention, just to make that distinguishment right away. We do not engage much with drugs. We just focus on strengthening protective factors, driving down risk factors, and as a result, the belief is that drug use is going to change. I know that in many areas there's this sort of distinction and lack of clarity between what happens between the primary, secondary, and the tertiary end of things. We are strong supporters of tertiary prevention. We're strong supporters of treatment bed availability, of treatments being offered and available for free to those that absolutely need them, but that's not our area of work. In other words, we believe that those should be separate. People that work in community building should work in that area. They shouldn't concern too much what's happening at the treatment level. And I think there are good reasons for that. Our main focus is on the adolescent social environment. Substance use is perceived to be a social attribute. It's something that happens. Basically, the environment produces risk factors. If the risk factors are too high, the odds of substance use initiation is raised. It is our job to build environments for children that drives down these risk factors. In many places, we like to point the finger at people and say, well, you just have to be more responsible, or you're making poor choices. When I am 13, from a poor area with no resources and a broken family, it's hard to point the finger at me. We work with well-established risk and protective factors in the lives of adolescents within these 4 domains. No time limit. That's another essence that I believe has been very important to us, that we lay emphasis on a long-term goal, our long-term change. This is not a sponsored project for 18 months. It's not something that takes 3 years to do. And unfortunately, in our world of short-term grantism, where we get grants to do something and then we are in a limbo of whether they can continue or not, is something that we have intentionally shied away from, because cultural change takes time. We emphasize quick and consistent dissemination and translation of annual results. Our surveys are annual to all people involved, both as a diagnostic and monitoring tool, again, for everybody, policymakers, administrative leaders, and practitioners, including parents. So when I was doing the work back home at the sort of early time of my career in this work, I met with parents probably hundreds of times in all communities around the country. And it taught me a lot. You know, they will ask very different questions than you will ask. They were right on the money in what's happening this very minute. What are the latest risk issues? What are the new modes of using? What are the new modes of distribution? Many people would ask questions, are you looking at sex as well? Is that involved there? Are you looking at sexual risk behavior? And so they will be very kind of current. And our aim is to create a collaborative dialogue between researchers, policymakers, and practitioners. I want people in practice, people on the ground, to contact me and ask what the data means. And I want to go out there and I want to talk to them. And we want our people to be trained to do this collaboratively. Consistent, annual, repetitive cycle. So, how does it work? Remember, research, policy, practice. The role and responsibilities of researchers. We define risk and protective factors. We collect, process, and analyze data. We're trained to do that. We write national, municipal, and school community level reports, and we disseminate them quickly and effectively to all involved. We then present, translate findings to policymakers, including elected officials, and obviously we would direct our talk differently if you were a room full of elected officials. Municipal and school community level, school faculty, prevention workers, and really everybody else, including parents. And we recommend and make recommendations for interventions to all these people. That is the role and responsibility of researchers in this triangle. The role and responsibilities of policymakers and administrative leaders is primarily, and this is how it's happened in Iceland, of course, is to procure funding and make sure that we have protected time paid for, both at the national and municipal levels, to pay for the research. We do long-term contracts with them so that we can have access to the schools. We will collect the data and do the dissemination piece. Local prevention personnel. As I told you earlier, I can't have access into local communities. I am not a local. I'm not a local champion. I don't have the local trust. I don't have the know-how. People don't know me. They don't know where I'm from. They don't know what I'm about. If I can work with people at the local level, however, that are rooted in the communities, they are obviously much better geared to that kind of work. So the municipalities will fund local prevention personnel. They will fund organized recreational and extracurricular activities, which we know are very important for the leisure time piece in the prevention system. They will also promote and try to make sure that children participate in these kinds of activities on a very consistent, regular basis. They will often fund other type of interventions that may be locally tailored and specific to their environment, because this is not a universal top-down system. There isn't one intervention that's going to work everywhere. And of course, they fund NGOs that have specific focus, such as, well, two of them are called Home and School and Together Group, which concern mostly the parental to school and community collaboration. The municipalities will also facilitate the population access to the research piece. Everything follows the data. Everybody follows what's happening with the data on an annual, consistent basis. And they will pass laws and set directions for prevention and health promotion work. Practitioners that we often call local champions, they work locally. They are prevention specialists at municipal, district, and school levels. They're youth workers, they're faculty and other school personnel at the local school community level, and most certainly they are parents. They will organize, support parental organizations and involvement at the municipal and school community levels. Having a strong parental community within each school, if there is a golden egg in this system, that is it. If we can have access to parents through strong structures within the school system, that is really, really a key relationship. Organize municipal level and school community meetings with professionals and parents. So commonly, when we go out there to meet with people at the local level, the best meetings are if we can meet local professionals, local prevention workers, school faculty, and parents all in the same room. That's when the light bulb comes on very often. They assist in setting strategies and goals for the years ahead, for the next year ahead, and certainly enforce and support locally tailored interventions that may be of various different kinds. Facilitate a dialogue with the parent community. Really, their job is in many ways focused largely on the parenting community. And promote participation in organized recreational and extracurricular activities. And we have certain interventions that focus on that specifically. So I gotta speed it up. In other words, we can learn, all can learn from another. You know, we are not working separately. We have to try to integrate. So as a researcher, my limit is also that if I'm gonna have access to community, I have to have community partners to work with. One thing very important, for us to be influential, we have to be able to write and disseminate results that are clear and geared towards the level of implementation. So let's say that you guys are a room full of parents in a given high school. This is a very active parenting community. And I bring you findings with a random sample from the province. How are you going to believe that the findings attribute to your children? In other words, to achieve the buy-in, the analysis and dissemination need to fit the level of implementation. So we lay great emphasis on creating city-level reports for city people, community-level reports for community people, and even school community reports for those. A few key intervention activities before I run through a few results. So consistent annual report dissemination, translation of results to all involved. This is the public health education piece of it. This is annual, repetitive, basically spewing of information all the time to all these areas. Efficient parental groups in school communities. Increased parental monitoring and co-communication at the school level. And a few things that we've done for that are, for example, parental walks. It's sort of like a gathering of parents in communities to get to know one another. And there is an NGO that enforces or facilitates something called the parenting contracts, which are basically sort of an agreement that parents in a given school come together that we are going to follow certain rules together. Because all parents, if you ask them, all parents are tired of being the one with the finger. The one, no, you can't do this. No, you can't do that. No, you can't be outside late. No, you can't go to this party. Every parent agrees. No, I'm sick and tired of being in this position. The leisure time card has been something that has been effective, particularly in Reykjavik, which is like a prepaid check or a voucher, basically, for kids to participate in organized leisure time activities. And those are very, very important as a preventative tool as well, to participate in sports or music or drama or something else. Absolutely no smoking and alcohol use policy before, during, and after school-related events. This should be a common sense, but absolutely wasn't in Iceland and before. And we have a curfew, actually, on outside hours. And you know the literature on late outside hours is pretty clear. Kids that hang out late at night outside doing nothing are probably up to nothing very productive. So a friend of mine, I always show this table because a friend of mine at West Virginia, who is actually a US-based scholar and an interventionist, he got really involved in this and was very interested in this. And he created this table to sort of demonstrate a difference between this approach and many other approaches. And I always show it just to demonstrate this is sort of the third eye of somebody that really knows intervention stuff well. Our system is long-term instead of short-term. It's collaborative instead of prescriptive. We focus on holistic change and a lot of different outcomes, not on an isolated outcome, which is, is often the preference of funders, for example. We view community as an absolutely central point of intervention. It's service intense. We want to provide service. It's service-oriented research. And it's not career and research intense in that sense. We definitely use the data for our own scientific needs as well, but that's a secondary aim of the work. And our idea is to sustain long-term benefits to community partners instead of just leaving them behind after we have collected data, which is unfortunately way too common. So Iceland has witnessed an absolute paradigm shift in standard rates of drug and alcohol use over time. In 1998, 42% of our kids in 10th grade had been drunk in the last 30 days. That rate is now 5%. 23% were daily cigarette smokers. That rate is now 3%. And 17% had used cannabis substances. The rate is now 7%. So clearly something absolutely massive has changed. If you looked at our position in the latest SBAT study, which was conducted in 2015, we are at the absolute bottom. 35% have used lifetime use of alcohol. The average is 80%. 9%, the only country with a single-digit number in a 30-day use of alcohol. And drunkenness has been almost eradicated. So clearly, a lot of things have changed. Sometimes we're asked, well, aren't these secular trends? Isn't this happening everywhere in the Nordic countries? No, it's not. There are some things that are definitely happening there too, but nobody is as excessive in its change than we are. So we are, in terms of binge drinking, at 8%, Norway at 19, Sweden at 22, Finland at 23, the Faroe Islands at 28, and Denmark at 56. So, we are definitely far, far ahead of most of them. This is an interesting figure that also demonstrates well our aims. Our aim is to push the initiation as far up as we can, is to delay the initiation or prevent them from beginning. There's countless cost-benefit analyses and all kinds of research on the fact that if you can delay the onset, you really have done well. And each of these lines represents an age distribution in a study we did in 2009 called the Nordic Youth Study with all the Nordic countries except Sweden. And it just shows a ratio of kids when they initiated alcohol use. Every line represents one country, and then it sort of peaks at a certain time. For example, Greenland here peaks at the age of 13 and a half. There's one curve that peaks behind all the other ones, and that is Iceland. Our peak is at the age of 16. We are a year and a half, or even more behind the other ones. So clearly, something has changed more in our backyard than it has in these other countries. What about risk and protective factors? Let's show you a few results. Parents and children spend more time together. In 1997, 23% of kids said that in 9th and 10th grade that they almost always spend time with their parents during the weekdays. That's 53% in 2016. Statement, my parents know where I am in the evenings, 52% in 2000, 80% in 2016. Rates of students in 9th and 10th grade that participate in sports with a club or a team 4 times or more often per week, 23% in 2000, 40% in 2016. Rates of students that have been outside 3 times or more often after 10 p.m. at night, 53% in 2000, 22% in 2016. Now, as you know, this system is about building community. It's not so much about drug use. So what other associated factors can we expect to change if drug use is changing in terms of risk and protective factors? One of them is bullying. This is numbers of participants participants that have been a part of a group teasing an individual once or more often in the last 12 months. 35% in 1999, 7.5% in 2016. And subsequent changes in other similar measures. Same for measures on theft. 32% committed any kind of theft of 5,000 Icelandic kroner or less. It's about 40 Canadian dollars in 1997, 13.9 2016. What about other places? Is this possible to replicate somewhere? We've been working with a number of communities, and one of them is Riga in Latvia, which is the capital of Latvia. They've done really well over the last 10, 12 years of following this trend as much as possible, and they've shown really, really positive results. I'm running out of time, so I just want to go through briefly evaluation. We did an evaluation study in 2009, which was published in Preventive Medicine. By the way, all this is published, and I'm happy to share it with whoever is interested, where we looked at communities that have been a part of this project from the start and those that have never participated. As you know, when you do community work, things get kind of messy. Sometimes communities participate for a little bit, then they have changes political leadership and they move out. Then they come back in 4 years later, or they may take only part in a part of the project. Those things are really kind of non-linear. So we did this study with communities that were a part of this project for the entire time and those that never did really anything with it. And to cut a long story short, we were able to find intervention effect to the most extent for smoking, intoxication, parental monitoring, participation in sports, and decrease in party lifestyle. So in some, substance use decreased more in intervention communities than in others, and the prevalence of protective factors did as well. We've also monitored our progress through the European SBAT studies carefully, and we see that our change has been more excessive than in other countries. We continue to publish. This is a trend analysis that we published on risk and protective factors and our situation, and all of this is out there if you're interested. So what are we doing differently? In short, we're not doing anything that many other places aren't necessarily doing, but just kind of organizing them in a different way. We're trying to speed up the process of collaboration, where that is an absolutely central part. We focus exclusively on primary prevention because we really think that if you build communities, you will have less problems downstream if you begin well at that end. We focus there on environmental change and not on individual responsibility. We don't want to point the finger at children. We want to say these are people that are our responsibility to produce as community citizens. I've been trying to do this in West Virginia for a few years now, and we are kind of stuck at the level of raising awareness. And the reason is that we don't have the community partners. We don't have the community links. We've done well with data collection. We've done well with creating links with schools, superintendents' offices, and data analysis, dissemination, and so on. And interestingly, the variable relationships with risk and protective factors are basically the same. As we know, those are universal, more or less. Rural Appalachia, totally different environment, still more or less the same. So the challenges over there are that, there is really no primary prevention infrastructure. We just don't have the access to people in the same manner as we have in our home country. Very weak and usually basically just inactive parental communities at the school level. So we don't have the links to the schools. The schools have more than enough on their plates. They cannot be made responsible for this. The county and the board and the municipalities have to step in that direction. Yes, it's rural. Yes, we've been told that there's problem of outreach and transportation and so on. But if you ask people, do you come to the football games? Yes, they come to the football games. So can they not come to the prevention meetings then too? So, it's a matter of also of just creating this kind of knowledge and interest. And obviously in Appalachia there is quite a bit of kind of limited openness to interference of this kind. People often say, you're not going to tell me what to do with my children, So it's a delicate, very kind of delicate thing, and they'll point at me and say, he's from the socialist north, he won't understand this culture or whatever. But generally speaking, the system, there's no reason to believe that it wouldn't work elsewhere. So if you're interested in publications, please get in touch with me. Thank you very much. Sorry I took over time.
Thank you, Alfgeir. That was terrific. We've got time, I should say, in case some people need to run out, 7 p.m. tonight is a follow-up. Alfgeir will be talking to our community, the larger community of the Waterloo region, 7 o'clock at Kitchener Public Library, and that'll be live streamed as well as videotaped. This is also being videotaped. We've got time for 1 or 2 questions before we go to a reception that did require registration, so I hope those who registered for the reception stay and join us for a bit. A question for Alfgeir. Yeah.
Back on? All right, thank you. Good question. Question was, how effective do you think this would be potentially in terms of other behaviors? We see clear patterns of change for some behaviors, but not for others. So for example, I showed you both bullying and theft as a measure of delinquency. We know those are definitely sort of a byproduct of a stronger community. But I wouldn't count on it working on for everything. People talk about, is it going to overlap with obesity and so on and so forth. I'm not sure about that. But definitely things that are related. We see that clearly.
Has there been any research around the sexual initiation, like having sex earlier or later, that kind of connection?
Yeah, very good and very common question. No. The reason is mostly that it's still too controversial, and especially with regards to the consistency of this. This is a boat that we cannot rock too much. We leave a space for changes, and obviously things change over 20 years. We now have e-cigarettes and excessive caffeine use and all kinds of things that obviously change over time. And sex is a question that comes up time and time again, I tell you, especially from parents. So we have designed some sub-studies where we have done work with that, but it's not sort of an integrated part of this work. But as we know that do prevention, there isn't one group in alcohol use and another group in smoking and the third group in sexual risk behavior and the fourth group in dropout prevention and the fifth group in violence. It's all one and the same group. So, I wouldn't be too worried that those things aren't hold hands, but we haven't done really any detailed analysis of that.
I'd be really interested in hearing how you took the language of researchers and put it into language that policymakers can understand, parents can understand, that made it real to them. I think that's our biggest challenge. For instance, we'll say improve mental health. We don't say improve mental health by.
Yeah.
And so I'd be interested to know how you did that, and did you pass it by people or?
Yeah, very good question. It's a skill. There's no question. It's a skill. When we report back into the community, we use bar charts and line graphs. We use no Greek symbols. When it comes to scaling, we basically provide, means and standard deviations and so on. But in terms of substance, it means much more to people to have individual questions. It means much more to people to hear what is the frequency of children that have sleeping problems, rather than what is the average of the blah, blah, blah depression scale for depressive affect. You follow me? So we will tease out items that we know appeal to people that really are resembled of the scaling. But I understand the question. It's a very good one. It's delicate and it's a skill, So we keep it simple, but they are definitely the most important pieces. And many of these measures are just count measures. We're just counting, how often did you do this, or did you do this at all, and so on.
Do you have any data about the utilization of the healthcare systems, or like mental health systems over the years of that project?
I'm sorry, can you repeat the initial?
How much the mental health systems were utilized? Was there any drop in the need for, let's say, psychotherapy services or psychiatry service?
Yeah. No, we don't. We don't have data on the need for the systems. But in our analyses, we have shown that this doesn't really impact mental health much. In other ways, our mental health trends do not follow these trends very well. So my sort of initial thought on that is that there are other factors at stake, although these may be important factors, that I'm sure many of them are. There are also other factors at stake. And obviously the problem here is that time goes by. Things aren't stagnant when there's time is passing. So there may be other things happening that we just don't know about. So I would not be comfortable in stating that, yes, it has impact on mental health, because I don't have that evidence.
I believe you mentioned something about a parental contract. And
Right.
I was just wondering if you could explain that a
Sure,
little bit.
sure. So one of the parts of the system is to fund NGOs that have a specific focus. And one of those is funded by the municipalities and called the home and the school. And it's about bridging the link and the collaboration between what happens in schools and what happens in the home. Oftentimes, we put parents and schools sort of up against one another. We put schools out there, and they're pointed at by parents and vice versa. The Home and the School is an NGO that really works about bridging those links. And one of the things one of the principal things they do is a parental contract, which basically they assign to the parenting community on the class level. They go into every class, and they talk to parents about the importance of collaboration. And part of that is they sign a contract agreement between them with set sort of common rules about, outside hours, homework, and so on and so forth. And this is something that is initiated by the parents. Obviously, not everybody participates in this and so on. But it's a mutual kind of agreement that supports parents in this sort of being the one with the finger, which they really is challenging. And having parents on board just generally in any aspect of this work is really, really critical.
Hi, everyone. I'm Troy Glover. I'm the chair of the Department of Recreation and Leisure Studies. I've been tasked with thanking Dr. Kristjansson for his talk today, so thank you very much for the thought-provoking and enlightening presentation on the transformative and sustainable effects of the Icelandic model, or I guess community building system as you described it, on youth substance use and abuse. The impact of the model you presented demonstrates the importance of the things we hold dear in the Faculty of Applied Health Sciences. Things like preventative health, social determinants of health, evidence-informed policy and programming, research impact, health promotion, prevention, and purposeful leisure. In a faculty that prides itself on leading new conversations about health and a university known for advancing innovation, your remarks sit well with this audience. No doubt they will inspire meaningful discussions about what we can do locally to better support youth in our community. On a personal note, your remarks underscore for me the amazing opportunities for greater collaboration between my unit, Recreation and Leisure Studies, and the School of Public Health and Health Systems, and other academic and community organizations. As you've shown, our interests can combine to address complex social and health problems and engage in culture change. So on behalf of the Faculty of Applied Health Sciences, please accept my sincerest thanks. Thank you.
Thanks, Troy. And thanks again, Alfgeir. This was terrific, beyond what a lot of us imagined was even possible, and we had high hopes. Reminder, the Crime Prevention Council event tonight at 7 p.m. at Kitchener Public Library. And I should tell you, Alfgeir has one more gig tomorrow morning. We've, for those of you who care about extra attention to that translation into action, tomorrow morning we have arranged for Alfgeir to sit with our key stakeholders in our community, mayors, city councilors, etc. And Alfgeir's going to make the case that something like this is possible in our region. So stay tuned. And thanks again, Alfgeir. It was terrific.
Oh,